If we access the key contributors to the healthcare burden across the globe, COPD is turning out to be a key contributor. Its steady rise is concerning healthcare professionals across regions. COPD ranks third in causing death. To make it worse, COPD management becomes complicated, especially with comorbidity. Turns out to be the fifth leading cause of dialysis. And still, it remains largely neglected by doctors and the general public. Despite affecting over 400 million people, little research is available as of today. While COPD assessment and management have seen positive changes with effective therapies, long-acting inhaled bronchodilators, GOLD guidelines, our world is yet to witness a life-changing solution to stop COPD's progression. So, the question remains, what is the way ahead in COPD management? Let's hear from the experts.
Hello, I'm Sujit Rajan, consultant pulmonologist at Bombay and Bhatia hospitals in Mumbai, and I welcome you all to Season 2 and Episode 8 of Healthcare Superstars. In the first season, we have seen some amazing cases of interstitial lung diseases, including IPF, COPD, and an asthma series as well. In Episode 8 now, based on audience demand, we move to COPD again. And in today's episode, we shall be addressing the much debated issue of diagnosis and management of COPD in a primary care practice. And before I invite our speakers, I would first like to thank our collaborators, which are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPath from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. I'd like to introduce our first faculty, Dr. John Hoffney. John is a dear friend, has been on Healthcare Superstars before. He's the past president of the International Primary Care Respiratory Group, IPCRG, and over 20 years has led various educational programs for both primary care and secondary care clinicians. He has over 500 presentations at PCRS, IPCRG, BTS, ERS, ATS, and the ACCP conferences. He's a regular trainer for the undergraduate training program at the University of Glasgow and the University of Aberdeen. John has over 74 peer-reviewed publications. So welcome, John, today. We look forward. And now to introduce our second faculty for today, Dr. Richard E.K. Russell. Richard has been on Healthcare Superstars before, and he is a consultant respiratory physician and a senior clinical researcher in respiratory medicine, NDM, at the University of Oxford and the respiratory lead at NHS England South East. He's also an honorary senior lecturer at Imperial College London. He's a scientific committee member of the BTS and a founding editor of the International Journal of COPD. Richard's current research focuses on the role of blood eosinophils in acute exacerbations of COPD. He's also a co-patent holder on the device for the remote collection of exhaled gases, including NO. He's an investigator in 16 clinical trials on COPD and has published over 35 peer-reviewed papers. So welcome, Richard, again to Healthcare Superstars. So welcome, John, to our show today, and welcome, Richard. Richard, over to you for the first case. Please go ahead.
Thank you so much. I'm going to talk you through a case and we can have a little discussion, and also maybe give you my views on how this could be handled. This was what you might consider a typical patient, and particularly in these COVID times when people are being seen less face to face, problems with diagnosis are occurring more often. So this is a patient, Mr. DS. He's a 50-year-old lorry driver. Now, this is quite important because lorry drivers don't do very much activity, very much exercise, and don't complain particularly about breathlessness. But he went to see his GP with a cough. Now, a cough is a very common complaint, and it's many causes of cough, from very sinister ones such as lung cancer, right the way through to much more mild ones such as post-infectious cough. However, cough's a common problem for primary care practitioners to deal with and is also a cause of secondary care referral. The GP saw Mr. DS and examined him. He did record in the notes that he heard a wheeze. So he actually auscultated the chest and heard a wheeze. He took a little history from the patient. He's not someone who comes to the practice very often, and he's been a smoker since the age of 17. So he's got 33 pack years or more smoking history in his lungs. And I would come back as a secondary care doctor, I focus on occupation quite a lot. I would come back to the fact that he's a lorry driver, because again, he may be just sitting up in his lorry, driving around and actually smoking quite a lot, which is a significant issue. But anyway, he had a wheeze and he presented with a cough. We then saw some spirometry. So this patient had his spirometry recorded, and actually his spirometry was not actually too bad. His FEV1, so that's the forced expiratory volume in 1 second, was 2.45 litres, and his FVC was 3.31 litres. This gave him an FEV1 to FVC ratio of 0.73. Now, this is not quite normal, but is certainly not absolutely diagnostic of obstructive airways.
Richard, do you feel this is a good spirometry loop? I know John is going to take us through spirometry and what primary care physicians are to look at in a small little talk after your case, but do you think this fulfills the criteria?
Well, the patient performed 3 tests actually fairly similar to each other. That's really important, that actually reproducibility is good. And all I can say is I didn't do it, but the patient actually was reported to have given a good effort, and that's also really important. So they are similar in that way.
Sure.
The peak flow was reached fairly quickly, which is also very positive. And this is a man, and actually men often blow fairly quickly and hard, and so they will reach a peak flow quite quickly. The thing that perhaps was missed a little bit on this spirometry was that actually the ratio was almost obstructive, but also can you see halfway down the decline on the spirometry curve, there is a little bit of a sagging, a dropping away. And this could be typical of airflow obstruction or early airflow obstruction. We sometimes call this small airways disease. So it's reasonable, but if it's abnormal, there's subtle abnormalities which are very easily missed. And as you said, John's going to speak about the details of spirometry, which we'll discuss later on.
And you wouldn't normally do a post-bronchodilator for these patients, would you? Or?
I think this is again something which I think I would discuss. I'm somebody who actually likes what I call quick and dirty spirometry, actually meaning it is there, it is live, and it's done in my clinic with me right away.
Sure.
Because I want to know what's going on then. However, from a diagnostic purpose point of view, correctly, this should be post-bronchodilator to give the best possible outcome. So it's very important potentially to state that actually that would be the best way of doing it.
Sure. Please go ahead.
So what happened? What did the GP do? Well, the GP's got a patient who's got cough. He diagnosed him potentially with asthma because he heard a wheeze, and he started him on some inhaled corticosteroids, which would be a reasonable initial treatment for asthma and certainly not necessarily a bad treatment for cough. Unfortunately, this chap missed his follow-up appointments, and that's a problem. And we picked the story up 9 years later now. This chap's now 59 years old, which is not a great age in any way at all. But he's come back to see the GP with a cough, with sputum production, so things have changed a little bit, that wasn't mentioned before, but also now with breathlessness. Now I really want to pick up on that because it's really important to detect and ask about breathlessness. Remember, this chap was a lorry driver, not someone known for lots of activity. So to be breathless, he actually has to be fairly disabled by this time. He was still smoking, and he continued to smoke through that whole period. So he now had over 40 pack years of cigarettes use in his lungs. He'd had 4 episodes when he asked of winter bronchitis. These had not been managed by the GP, these had not been put together, but actually been managed by a pharmacist in an informal healthcare network. That was a problem. He hadn't been admitted to hospital, he'd not actually been to the GP. So that's not such an unusual thing. But actually this story is a very common one.
Yeah, no, I was just wondering because John, you're a primary care physician. Do you see this happening often, that the pharmacist gives a prescription or gives some medication to the patient? And what would you do differently if you were the primary care physician?
So there's a few different potential scenarios here, Sujit, and as you rightly say, it depends very much on the health service that you find yourself working in. One of the common things that's happening in the UK at the moment is that patients have self-management plans for chronic bronchitis, which involves them being issued with antibiotics and steroids to take when they feel it's necessary. And this has had some good outcomes, but it's also had some very bad outcomes, because there seems to be a situation where patients are taking their therapy when they don't really need it. The first time they feel a little bit breathless, or they have a cough, or they feel tired, they're taking their steroids, and that's not something we really want to see. So we need to educate our patients well. But I think what COVID has done is it's pushed us into a situation where we're different ways of managing our patients, and some of these are more remote than they used to be, and there are pros and cons to that, because we might be missing important diagnoses, but we are managing to get treatment to some patients quicker than we might otherwise do. So there's definitely a role for the pharmacist there, but we're having to tread carefully to make sure that we don't routinely give antibiotics and steroids to people who have exacerbations or chest infections or discolored spit or breathlessness, without acknowledging that there might be quite different issues going on with those patients that need quite different treatment.
I agree, and I guess it's the simplest way out for the patient. Get a prescription, feel a bit better, and go on. So I guess that's what happened to your patient, right, Richard?
I think it's also the fact, patients will go and find help, and patients are sophisticated sometimes at getting help for themselves in their informal networks.
Right.
But one of the key issues here is, from a diagnostic uncertainty point of view, is recording these episodes so that we know what kind of patient this is, and if this someone is we're going to label perhaps as an exacerbator, that might lead to different treatment.
Right. But this gentleman, for 9 years, went on getting his medication and started getting breathless. So obviously nothing really was bad enough for him to alert his GP, from what I can see.
I think that's right, and I think that's sometimes, again, a good thing, because they're not that severe, but also in general that may well be missed opportunities, and I'll come to that towards the end.
Please go ahead, please.
So this chap then had repeated spirometry, and you can see, this is a typical kind of trace, that things had dramatically changed. Okay, his FEV1 was 1.2 litres, so a significant loss of spirometry of FEV1. His FVC had also declined to a degree, but he now clearly got airflow obstruction with a very significantly impaired flow volume loop. And again, we'll talk more about the patterns that we see very often, but this is a fairly typical pattern, very severe COPD in this way. The key point I want to raise here, though, and this is not uncommon in some people, it's unusual in everybody, but there'd been a significant loss of those volumes, and this would not be sustainable and compatible with a normal life expectancy.
Yeah, he's lost almost half his FEV1 in 9 years.
He has, and that's in 9 years. And and you can lose, I've certainly seen people losing 100 to 120 mils a year over time, and particularly if they're having exacerbations, that can make things worse and accelerate the process.
Sure.
So the diagnosis changed, and there was clearly an issue here now with severe airways obstruction, and it was referred to me for actually some help. I'm not going to go too much into the detail of what we did. However, the GP was quite correctly worried about the breathlessness. As I mentioned, breathlessness is not normal. It should be investigated extensively and carefully, but also should be asked about. And the GP had now, the penny had dropped that actually this patient was breathless and should not have been. The patient clearly was a rapid decliner, and this is a real worry too. And there was also a need for an accurate phenotype to work out what's going on with this patient and what treatments he needs. And, not unreasonably, you might think then, because of this rapid decline and this critical age, around 59, that actually you might want to consider interventional therapy, so we can use other processes in secondary care, and also potentially referral on to a tertiary centre for interventions which will actually improve this chap's lung function. This was his X-ray, and I can't even get it all on the screen. It clearly shows significant hyperexpansion, significantly flat diaphragms, a very narrow mediastinum with very few lung markings, vascular lung markings to be seen, suggesting significant hyperexpansion, potentially with emphysema. And this is a pretty typical kind of CT scan of a patient, very similar. And again, this is set to look for the lungs, and you can see here that there is very few lung tissue to actually be seen. This is obviously somebody with severe emphysema, which is a particular problem, and I wanted to draw attention to that in this case, because sometimes emphysema develops without significant airways obstruction until late in the game. So a patient may look, particularly men, may look really quite well, but in actual fact they are developing severe emphysema even though they can blow a pretty good peak flow or blow a pretty good FEV1. So what did I do? Well, I wanted to find out a little bit more what's going on. So we checked alpha-1 antitrypsin phenotype, genotype, and this chap has got MZ genotype, which in the context of significant cigarette smoking is a problem. Would maybe lead to accelerated loss of lung function. He's not a ZZ deficient, which would be the worst kind, but he's an MZ, which has got some deficiency of alpha-1 antitrypsin function, but that's not quite enough in general. We check his blood eosinophils. This is an important thing, which we may talk about a bit later on, but actually his eosinophil count was actually fairly low, 120 cells per microliter. Immediate treatment. We optimized and maximized his therapy. 3 things we did straight away and were clear with him. 1, we put him on a dual bronchodilator. His eosinophils are not high enough necessarily to lead to a steroid straight away, and the steroids haven't done him any good. Dual bronchodilators are absolutely the mainstay of therapy for this. Number 2, we put him through a pulmonary rehabilitation course when he had his treatment optimized. And number 3, we actually put him through an effective smoking cessation program to stop him smoking for the future. So those things are all going to affect his prognosis in a positive way. What about the future? Well, this chap with a rapid decline may well continue to decline even if he stops smoking. So we might want to consider lung volume reduction surgery, bulectomy, or even a single or double lung transplantation. Now in the United Kingdom, we transplant people generally up to around the age of 63, 64. So again, it's very important at this age of now 59 that we get to grips with his problems and actually consider all options for this chap. Otherwise, he's going to be in trouble.
Sure. And I think, Richard, a lot of the things you mentioned in terms of maximizing therapy could have been done in primary care, you believe? The bronchodilator?
Very often they do. I think that's a really good point. And actually, as John mentioned, it depends upon the setup that you have and your national setup and the integration you have.
Right.
And we are generally lucky in the United Kingdom in that we're generally quite integrated, in that GPs can order, often nowadays, alpha-1 antitrypsin genotyping. They obviously can do full blood counts. They can order CT scans as well, very often actually, depending on local policies and access, but certainly can refer through to rehabilitation, smoking cessation, absolutely essential, and obviously prescribe appropriate bronchodilators. But I think with this chap, he was just missed, and not necessarily the GP's fault, because as I mentioned, he didn't present in those intervening years.
Sure. No, but I think a lot of what you mentioned could be done by an alert primary care physician. The bronchodilator could have got on. Rehab referral is not a big challenge, and it would help such a patient tremendously. And of course, rehab could also double up as counseling for smoking cessation and therapies if they were required. So a lot actually in the management could be done at primary care, I see here. John, do you think all this happens, or is this a common scenario or an uncommon scenario? What would you think?
This is a common scenario, Sujit, and I think the sad thing is, for whatever reason, there was a 9-year gap.
Right.
So why did he allow things to deteriorate?
Sure.
Did he feel he couldn't speak to his general practitioner? Did he not recognize there was an issue?
Sure.
Did he put it down to other reasons? It's just my smoking.
Right.
Did he know that if he contacted a healthcare professional, the first thing they would do is tell him to stop smoking,
Right.
which he probably doesn't want to do but needs to be reminded to do? Did his GP not make himself accessible enough to have a discussion with him?
Right.
Was he called for regular health checks at an appropriate age where these things could be raised? At the very least, encouraging to stop smoking, probably to exercise a bit more, would have helped. Making a diagnosis, identifying that he's a fast decliner in FEV1, it's going to help an awful lot. That's a strong incentive to stop smoking. To know that you've got alpha-1 antitrypsin deficiency and the implications of continuing to smoke. Lots of missed opportunities here. But I don't think we should always blame the patient. For whatever reason, the patient couldn't or wouldn't contact his primary healthcare team. And I think we need to make sure that we're as accessible and open, non-judgmental, supportive as we possibly can be to make people like lorry drivers. I live in Glasgow, a big post-industrial city where men are men, and we are all think ourselves as tough and hard and so on. But actually, smoking's not good for you no matter where you are, and you need to be able to access advice and healthcare as appropriate.
Sure. I couldn't agree with you more. A lot of missed opportunities there. I think just a spirometry test, maybe after a couple of years, down that 9-year gap, would have helped, probably pick up a decline. And we know that lung function decline, the decline has begun even earlier than that. So a lot of education could have gone in there. Unfortunately, the three things that Richard put up there: bronchodilators, rehab, smoking cessation, everything could be done in primary care. Everything. There's only the real tough ones, that is surgery and the transplant, which really need tertiary care. And I can see that missed opportunities a lot, and we hope that doesn't happen. Yes, Richard, and do we have the...
I would say...
Yes, please go ahead.
Sorry. I would certainly add, I think John's absolutely right. Very important. Patients think we're going to tell them to stop smoking, and that's the thing they don't want to hear. Right. And in fact, we need to be supportive of that and be frank and say, yes, it's really important to do that, but actually do it absolutely in a non-judgmental manner. Yes. And acknowledge what smoking is, which is an addiction, and it's not a blame game. But patients have that level of guilt sometimes, which they should carry. So we've got to really help them with that and enable them to connect better with us.
Richard, anything further on this patient?
Yeah, I've got two final slides, which we've already discussed a lot of this.
Sure.
Very important points to remember, everybody out there. Everything which you hear a wheeze is not always asthma, okay? COPD can wheeze, bronchiectasis wheeze, foreign bodies, etc., and obviously including lung cancer. So we need to be thinking. And if you hear, one thing this GP did very well was actually make a diagnosis and give some treatment. Unfortunately, they got lost to follow-up, which would have been lovely to see, and that would have maybe solved the problem. But actually, just remember, when you hear a wheeze, don't assume it's asthma. And then making a diagnosis of asthma or COPD, in typical cases, is very simple. Clinical signs, the symptoms, the episodicness, the variability, maybe just the cough, where COPD has got progressive disease and it causes sputum reduction and cough over time. But it takes time to become established. The objective measures, we've talked about spirometry, and we've talked about maybe about tests that you might do for asthma. And then thirdly, you do need to do the follow-up, very importantly. So to conclude about this case, and we've discussed much of this already, what are the lessons learned and the missed opportunities here? Well, I'm really keen. Our jobs as doctors is to make a diagnosis. And I really want to be as positive as possible about making a positive diagnosis of asthma or a positive diagnosis of COPD using all of the tools that I've got at my disposal, not just spirometry, not just auscultation, but maybe using nitric oxide, blood eosinophil levels, imaging, and doing challenge testing. Asking the right questions about childhood atopy, the impact of breathlessness is so important, whether we're looking at asthma or COPD, and of course the exacerbations. We've already discussed the impact of winter bronchitis. And then finally, the last two things really are confirming treatment response is so important, because if you've got someone who's got symptoms that you think they've got asthma, then giving them some treatment, fantastic, inhaled corticosteroids is really important for therapy. But you've then got to demonstrate the fact they're better. Did the treatment work? Because in asthma we would expect it to work, in COPD not so, and that requires effective follow-up. And as John mentioned earlier on, if we don't have systems which talk to each other very well and aren't joined up enough, then we can miss patients like this and they fall through the Swiss cheese. So being integrated is really important. There's some tests there I've just mentioned about metaclone challenges, pheno, and sputum eosinophils, all of which are not perfect, absolutely not perfect, but all can actually help you in the diagnosis of asthma, and all certainly pheno is becoming more commonly used in primary care now. Sputum eosinophil count and metaclone challenge are secondary care tests or even tertiary care tests, but you can use some other tests with reversibility testing and peak flow variability. So where did we miss this guy? We missed this guy's opportunity as a smoking cessation. That should have been done straight away. We should have had better links in healthcare services. And I just want people to think about this particular phenotype a little bit. Men, smokers, with relatively normal and relatively preserved spirometry, but can end up with very significant emphysema. So I hope you've enjoyed that. I've very much enjoyed the discussion we've had. And I'm looking forward to the next section, but happy to discuss it much further.
I think it was outstanding. And you know, the recognition of the alpha-1 antitrypsin phenotype, pheno, imaging, I think these are challenging for the average general practitioner, Richard. Though I see how much, as a COPD specialist, how much you delve into it to get to the bottom of that diagnosis, to give the best possible personalized care to your patient. So there's no doubt about it that your workup is just so comprehensive. But you know, I realize, and I'm sure you realize too, that the average general practitioner across the world has just about got access to spirometry, and sometimes not even that in some parts of the world. And the case was excellent. It highlighted some fantastic points, and we're going to have another case at the end of it. But what I want to tell the audience is that spirometry is really the base investigation that many general practitioners have. It's not enough, as Richard rightly told us, but you've got to get your basics in spirometry right. And that's why I've requested John to give a short 10-minute talk on spirometry. We are not here to tell you all how to do the test. It's beyond the scope of primary care physicians to sit down and do the test. We need good technicians for that. But I think if you can recognize what is a good flow volume loop, what's a bad loop, where are the issues there, and what to look at in a test, you will probably be much more empowered in diagnosing airway disease and treating it better. So thank you so much, John, for agreeing to this short talk. And we'd love to just hear you talk before we go to the second case, which you will present. Over to you, John.
Thank you, Sujit. You've asked me to run through some of the issues around spirometry from principally a primary care perspective. And what, Sujit, you specifically asked me to do was to look at some of the technical issues. Now, this is quite opposite, because the last thing we discussed in Richard's case was somebody who had a fast decline in their FEV1. This famous Fletcher-Peto curve goes back to 1977, when I was starting medical school and Richard was probably in primary school. And what Fletcher and Peto did was they described how FEV1 deteriorates over time, particularly in smokers. So the red line that you see here are people who are declining quickly as a result of smoking. And the top black line are people who, the other situation, the scenario we discussed, people who haven't smoked or are not susceptible to the effects of smoking, who have a gradual and much less severe FEV1 decline over time. One of the important things, and this is opposite to Richard's case, is if we had intervened with appropriate intervention, stopping smoking, encouraging exercise, pulmonary rehabilitation, we may have had a scenario of this yellow line where the patient stopped smoking. The FEV1 doesn't improve, but it declines at the rate it would have declined had the patient not smoked. Now, if we look more closely at Fletcher and Peto, it's probably not quite as simple as this, but there's a strong, simple message here that if you stop smoking at an appropriate time, your FEV1 won't decline. And this is all around spirometry and frequently measuring FEV1, so we can identify the fast decliners and intervene appropriately. Now, there's basically two types of trace you'll see with spirometry. There's a flow volume loop, and these are the readings which Richard's patient displayed, and also a volume time curve. Now, the good news is that in general, all spirometers nowadays will give us a printout of the values we require, such as FEV1, FVC, and the ratios, and a whole lot more, but let's confine ourselves to these two most important features for the basis of this talk. But you'll see there's a flow volume loop which measures the air flow over against the volume, and the volume time loop, which is shown on the right here. So if you have abnormalities, and Richard's already shown some of these with the flow volume loop, you'll see how a mild obstructive or a severe obstructive flow volume looks, and how a volume time curve is different for an obstructive pattern and a restrictive pattern. In the volume time curve, it takes longer for the air to get out, so the FEV1 is going to be lower, the amount of air you produce in 1 second. And the restrictive shows that you don't achieve your full forced vital capacity. Spirometry is a lot more complicated than just those two readings, and if you have an interest in lung physiology, this is the kind of graph that you might be interested in, which displays the different physiological measurements that can be made using spirometry. But for primary care clinical reasons, the two most important ones are FEV1 and FVC. So the FVC, the forced vital capacity, and the FEV1, the amount of air that's blown out in 1 second, translates into the kind of clinical values that we use to make confirm a diagnosis of COPD and assess the airflow obstruction in terms of severity. Now, when I was a young doctor, this is the kind of spirometer that we used, and this gives you a flow volume reading. And I have to say that my early experience with flow volume curves has led me to continue to favor them in terms of my clinical practice, because I've used them all my life and I understand them. These things were genuinely, a bellows spirometer were genuinely in use for the first 10 years of my clinical life, before things became more electronic. And this is the kind of device that many of you will now have, a micro lab. The one thing I would point out is that a good spirometer will have a paper trace. It can have a visual trace if it likes, but we really want paper confirmation that will allow an observer to confirm that the spirometry tracing is accurate and useful. One of the things you'll see in the bottom right-hand corner is that these things are not particularly cheap, but this was from a search of an internet search engine that I carried out at the weekend. And I have to say that it got 5 stars from 48 users. And that's the kind of commendation that my wife finds appealing when she's looking on the internet. So certainly considered valuable by our peers. And then the other thing that I want to come back to, we'll leave that just now. So Sujit was particularly keen that I went through some of the anomalies we can see in tracings. So we need a paper trace, and I'm going to show you some of these now. If you've got a good trace, you'll see that the curve is smooth, has no irregularities, curves upwards, and reaches a plateau. So this is a very normal, very good trace. But not all traces are like this. This patient, and as Richard said, usually a tendency in women rather than men who are not as aggressive at blowing, didn't try hard enough. So they got there in the end, but we can't get an accurate FEV1 because the patient didn't blow hard enough and fast enough as is required. This is probably going to get caught in the general procedures, because we're going to ask our patient to repeat the spirometry, and they'll find it very difficult to blow at exactly the same wrong pace. So we should be able to pick up these because of lack of consistency. But what's happened here is the patient has had sub-maximal effort and not tried hard enough. In this case, and this is possibly one of the most common things we see, there's an early stoppage. The patient blows and then they stop. If they'd continued, they would have blown further and improved the FVC. The danger here is that by stopping early, what we see is, as a result, is something which resembles a restrictive pattern. And it's important to know that the patient has completely emptied their lungs. Otherwise, we're going to get a restrictive type pattern, which is in fact spurious because it's been caused by early stoppage. The next one is a patient who coughs, and we see these rather strange but understandable anomalies in the trace because the patient has inhaled and then coughed. So it's an irregular tracing and quite easy to spot. An extra breath is a little bit more subtle, but if you've seen that once, you won't forget it. The patient breathes satisfactorily and then takes an extra breath and continues. The FVC is going to be much higher, but we're going to pick it up because the curve is abnormal. Slow start, very common. So a good blow, but happened too late. The FEV1 becomes delayed, the genuine FEV1, so the FEV1 reading is vastly reduced. So we can actually work our way through them. Here's our correct trace. Here we've got some errors in spirometry traces. What happened here? Here's the correct trace. What's this one? We've seen it before. Coughing. What's this one? Late start. What's this one? It's a breath in the middle. And these account for most of the anomalies that we see when we're doing a volume time spirometry. This one, early finish, could easily be mistaken for restrictive. Now, this little device is something that we're going to talk about later because this is very popular. It measures your FEV1 and FEV6 and works rather like a peak flow meter. The patient blows hard for at least 6 seconds and it will give us an FEV1 and an FEV6 reading. And if you've blown for 6 seconds, it's a reasonable assessment of your forced vital capacity. So by using these devices, which are considerably cheaper than full spirometry, about £100, $130 US for a device like this, we can have an FEV1 and an FEV6 reading. But what we can't have is a trace that shows that the patient has performed the procedure correctly. We need to discuss that. Much, much cheaper, reasonably useful, but prone to error by the patient. We need quality assurance for spirometry. It doesn't matter if it's done in primary care or secondary care. People say we should have relaxed vital capacities, forced vital capacities, maximum of 8 blows, 2 blows within 5% or 100 mils. We have to repeat it again, perhaps, with bronchodilators if we're looking for asthma. That can be quite challenging to both be quality assured and to make sure that the patient doesn't become exhausted by having to do this 8 times. It can be exhausting to do spirometry. Now, I want to put this in a little bit of context from the UK scenario. This is a poster we presented at the Primary Care Respiratory Society less than a month ago. And what we did was we looked at the rules for competent spirometry as described by the Physiology Society in the UK and how well UK general practice achieved them. So I'm going to pick up some of the figures and tables. So what we need to be reassured about is operator competency, make sure the equipment's well calibrated. And Suji, this can be a problem in primary care more than secondary care, where the equipment isn't used every day or every morning and afternoon. Patient preparation, correct performance, post-bronchodilator readings, and the quantification of a slow vital capacity. These were the things we assessed our performers against. And when we looked at the traces, this is what we found. Now, I've spent a little bit of time discussing the poor trace, but the poor trace was only responsible for 6.6% of the unsatisfactory spirometry. And some of the more common reasons were insufficient blows, failure to be reproducible, no record of VC, and so on. In terms of the poor trace, we had an extra breath in a few, a cough in a few, an abrupt end in a few, a slow start, and an indistinct trace, meaning the machine hadn't got the right amount of ink in or hadn't printed properly. I would say, Suji, and this is something I want to discuss with you later, that the reason for the small number of poor traces was because of high operator competency. Because the best person to spot a poor trace is the operator. the person conducting the spirometry, because by the time it gets to the reader, the GP or the specialist, we want to make sure that we have sufficient good traces. And if we're not getting good traces, then the operator should be identifying these and giving us further traces to make sure that we can make an accurate assessment of the patient with the spirometry we have. Now, what we did then, Richard, and this is a point I want to discuss with you, is we had the patients who had conducted spirometry according to the rules, to best practice. And we had others who had some spirometry, but not entirely compliant. And unfortunately, earlier you used the word quick and dirty. Now, when you said you liked quick and dirty spirometry, I think you meant quick, but not necessarily unsatisfactory. And one of the things I was slightly concerned about looking at these two lists of figures is that there was quite a number of patients had a restrictive pattern in the non-ARTP compliant. And I would suggest this is spurious because of probably stopping too quickly. So we're getting different readings between good spirometry and bad spirometry. The question's going to be, is bad spirometry good enough, or should we completely reject it? So the discussion points I want to have with the two of you now are as follows.
Okay, I think they're really good questions. In a way, yes, spirometry is important because it's how we define these diseases. Do I think that may be the future? No, I think things will change, but we'll talk about that maybe a little later. Quality assured spirometry is obviously really important if you want the right answer. However, the point I was making really about using quick spirometry is that actually if your spirometry trace shows there's a problem, it then means you need to go on and do a quality assured spirometry to actually assure it. If there isn't a problem with your quicker spirometry, which is easier to do, then you may not actually have a problem which is useful. So it's useful, as I said, in the moment, but it may mean that with my patient, for example, they might have picked up an issue with a decline, or even though the spirometry wasn't done with reversibility, even though the spirometry might have been quicker, which would then have led to a proper quality assured spirometry being done later, that would have then picked the patient up. And I think that's quite important. And then the FEV6 machines. This is really, it's not controversial, but it's really interesting that they've not been picked up and they're not widely used. Because as John said, they're cheap, they're simple. They certainly have the real problem that you can't assess the quality of the blow, and I think quality of the blow in spirometry is everything, as John showed in his poster. That really, I'm absolutely sure the restrictive patients being overdiagnosed is all about effort. It's all about not taking a big enough breath to start with and blowing it out in the right way. So does FE6 help you with that? No, it makes it maybe worse because they are very much don't give any feedback on the effort.
Sure.
However, once again, they do give you an FEV1, and actually FEV1 may well on its own have picked up my patient, because my patient's FEV1 decline would have maybe you could have picked that up maybe at 2 years.
Yes.
And now that would have been really potentially useful. So I think in certain situations where you can manage with just an FEV1, I think that's quite important, then actually these FEV6 machines are actually very useful.
Thank you so much. John, over to your second case.
Thank you again, Sujit. I'm going to take you through a COPD case. One of my patients, this gentleman's called Jeff. He's 62 years old. He's breathless, walking to the shops nearby, and as we discussed earlier, he's in a little bit of denial because he thinks it's just his age. He's not as fit at 62 as he should be. In terms of comorbidities, he's got a little bit of osteoarthritis. He smoked 10 cigarettes a day for 40 years, which gives him a 20-pack year history, which means he satisfies the conditions for having COPD if that's something we decide is on our differential diagnosis list. Meet Jeff's doctor. Jeff's doctor is wearing a white coat. He looks like an American comedian. He's waving his stethoscope around. I've maybe a few doubts about his clinical competence. And Jeff's doctor also thought it might be his age. He didn't take it too seriously. He said, Jeff, you're just not really as fit as you used to be. You're 62 now, but you're here to see me, so I think I'd better do something. So why don't you try this inhaler? Just see if it helps your breathlessness. So he gave him a short-acting beta agonist, PMDI, press and spray reliever for his undiagnosed, possibly clinically important breathlessness. And Jeff came back to see his doctor and he said, I'm better with this inhaler, doctor. I can use it 3 or 4 times a day if I need to walk or climb steps. If I'm breathless and I use this inhaler, it works. So thank you so much. What an excellent doctor you've been, without taking any history, without examining me, without doing any tests. You knew exactly what my problem was and you cured it. So they agreed he should continue his medication, but then Jeff remembered something he'd heard at a lecture at a postgraduate medical meeting, and it was, if you need a reliever, a blue inhaler, more than 2 or 3 times a week, then you should be on a steroid too. Jeff's doctor remembered this and he thought that was important, and Jeff has just said he uses it 3 or 4 times a day, so shouldn't he be on a steroid inhaler? Well, this is where Jeff's doctor got his information from. Your doctor will prescribe steroids for your asthma. They'll prescribe the lowest dose of steroid medication. For example, your GP will prescribe steroid medication if you're taking your reliever inhaler 3 or more times a week. Well, Jeff's taking his inhaler 3 or 4 times a day, so surely he should be on a steroid. No, Jeff's doctor, that's asthma. You haven't made a diagnosis of asthma. Jeff's a smoker. You haven't made a diagnosis at all, but you certainly haven't made a diagnosis of asthma. So don't confuse asthma and COPD. Jeff's doctor, you're going to have to make a diagnosis, and you're going to have to understand there are different treatment regimes for patients with different diagnoses. Asthma and COPD are not managed the same way. Jeff's doctor had confusion over pulmonary diagnosis, COPD, chronic obstructive pulmonary disease.
I think it's an outstanding example, John. The example you gave is just outstanding in terms of how many patients land up getting prescribed a steroid inhaler because they're thought to have asthma rather than COPD. And this is so 3 to 4 times a week. I love the way you put that across. 3 to 4 times a day. Gosh, he needs an atom bomb dose of inhaled steroid, and there he goes onto it. So go on, please. I couldn't agree more there.
Okay, so Jeff thought he'd better find a new doctor. So we found this guy who seems to know a little bit about COPD. And this doctor had a different approach. He thought he would take a history, consider the comorbidities, look for red flags, confirm a diagnosis with spirometry, check the MRC score, which is 2. He can't keep up with his compatriots. I just put this in just in case which part of the world you come from. So the MMRC score and the MRC score are exactly the same, apart from the MMRC score is counted as 1 less. If you're going to be dichotomous, if you're going to be binary, the important score is an MMRC of 2 or an MRC of 3, which means you can't keep up with your peers, which means you're functionally breathless. So Jeff had an MRC score of 3, which is an MMRC of 2. On close questioning, it appeared he has never had an exacerbation. He has not had what he might call a chest infection or winter bronchitis or an episode of smoker's cough or a COPD exacerbation. And our new doctor decided there would be a non-pharmacological and a pharmacological management approach to managing Jeff. So Jeff had his spirometry done. He's got an FEV1 FVC ratio post bronchodilator, as we know this doctor always does, of 66%, 0.66, which categorizes him as having an obstructive airways disease, and a post bronchodilator FEV1 of 69% predicted, which falls into the moderate category, but is, it's the milder end of what we see in terms of obstructive airways conditions. Now, once again, I went to the international guidelines for chronic obstructive lung disease just to confirm to you that what Richard and I and Sujit are talking about today is based on what guidelines say. So we make a diagnosis with symptoms and risk factors and then confirm it with spirometry. We must have exposure. We must have exposure to cigarette smoke in the Western world, or smoking or indoor cooking smoke or something else that would count as a lung irritant elsewhere. And then we make an assessment based on symptoms and exacerbation history. We have initial management, we've heard about this already, smoking cessation, vaccination, active lifestyle. In this list, pulmonary rehabilitation doesn't actually appear, but active lifestyle and exercise is the first part to that, and pulmonary rehab is that plus much more. And then in terms of reviewing the patient and adjusting pharmacological and non-pharmacological therapy. Interestingly, in previous iterations of GOLD guidelines, they would have listed the airflow obstruction as mild, moderate, severe, or very severe, but they wouldn't include it in part of the assessment in terms of thinking about your initial pharmacological treatment. And I think that's quite interesting that they've dropped it completely until you look at it from a patient's perspective, because my patients come in and tell me that they're breathless, or they're functionally disabled, or they have trouble sleeping, or that they've had exacerbations. And I'm still waiting for my first patient to come in and tell me that they think their FEV1 might have declined 30 mils over the weekend. So spirometry and airflow obstruction is important for the reasons Richard discussed with us earlier, but in terms of choosing your initial pharmacological treatment, we're only interested in two things. One is your breathlessness, as measured by your MMRC, MRC, or CAT score, and the second is the number of exacerbations you've had. So in terms of looking at Jeff, he's had no exacerbations, so he must lie in this bottom row, and he's got an MRC of 2, which means he must be in this right-hand column, which means he is Group B. And the suggested treatment for him is long-acting bronchodilator and no mention of inhaled corticosteroid whatsoever. Now, GOLD gives us some advice. This is the most recent iteration of GOLD as to when to consider initiating ICS treatment. And they're suggesting that ICS treatment might be useful in patients who've been hospitalized, who've had frequent moderate exacerbations, more than 2 a year, who have a high blood eosinophil count, and Richard will tell us about that earlier, or who have concomitant asthma. And you should not be using it in patients who have a history of TB, a low blood eosinophil count, or repeated chest infections or pneumonia events. So we've got strong support on one side, we've got strong advice against using them on the other side, and somewhere in the middle, the use could be considered. The goals for treatment of stable COPD, and we should always have goals in terms of managing our patients, according to the guidelines, are to reduce symptoms and to reduce risk. They mention risk of disease progression and exacerbations and mortality, but we must also reduce risk of doing harm to our patients by giving them an inappropriate treatment that might cause them more harm than good. In Jeff's case, we're going to relieve his symptoms, we're going to improve his exercise tolerance, we're going to improve his health status. As a bonus, we're going to help to reduce his disease progression. Now, what's the advice on the risk associated with ICS use? As long ago as 2010, NICE, who provide advice for GPs and specialists in the UK, asked us to be aware of the potential risk of developing side effects, including non-fatal pneumonia, in people with COPD treatment with inhaled corticosteroids. Now, the important thing here is that in the right place, ICS are very useful at helping us to manage patients with COPD. In the wrong place, ICS are going to increase our risk of chest infections, non-fatal pneumonia, and have no benefit. And we know this from EARN study and from TORCH. So we looked at the European Medicines Agency, looked at the risk and confirmed there was an increased risk. One of the things they were careful to say, because of disagreements amongst pharmaceutical companies, was that one inhaled steroid did not appear to be worse than another, although the dose or the potency of inhaled steroids might be important. So we know from the PATHOS study that there is increased mortality in some patients. We know from this study, which looked at a variety of inhalers with different constituents, all made by the same manufacturer. so we've got 2 bronchodilators, a single bronchodilator and a triple therapy, that there was a greater pneumonia risk in patients who were given the triple therapy. Now, if you give an inhaled corticosteroid to somebody who is not at risk of exacerbations, then you increase their pneumonia risk. If you give an inhaled corticosteroid to somebody who is at risk of exacerbations, you reduce the risk of exacerbations more than you increase the pneumonia risk, and therefore it's beneficial to the patients. We're going to discuss that shortly. I just want to show a slide some of you will have seen before, and it's about homogeneity. So this is the City of London, which is a homogeneous city. It has a centre with bright lights. It has a ring round it, which is the M25. The lights which are bright in the centre disperse as you move to the outskirts and eventually find yourself in the country shown black. You can see Heathrow at 9 o'clock, the very far left. But this is homogeneous, bright in the centre and spreading out. This city, which is Berlin, is not homogeneous. On the left-hand side, you'll see a greenish tinge. On the right-hand side, you'll see an orange tinge. This is because 30 years ago, Berlin was a divided city, and West Berlin used mercury lights, and East Berlin used sodium lights. Now, when we think about patients who need to get steroids for their COPD, then we don't think about London. One size will not fit all. We'll think about Berlin, where even though we have a population of people with COPD, some will need inhaled corticosteroids and some won't. And we have to think about whether you're in the one part of the city, part that needs steroids, or the other part of the city, the other part of the disease, the ones that doesn't need steroids, and make sure we use the treatment appropriately. So, my learning points are that COPD and asthma are different conditions. We have different pathways. We have different approaches to management. ICS, inhaled corticosteroids, are the cornerstone of asthma treatment. Bronchodilators are the cornerstone of COPD treatment. But it's not just about treatment, it's about all the other things that Richard's already spoken to us about smoking cessation, about pulmonary rehabilitation, about dealing with comorbidities, because we don't look after COPD patients. We look after patients who've got COPD. And because of the nature of the insult, smoking, because of the age of the patient, we're likely to find that patients with COPD have got comorbidities. So let's not forget that patients will have other conditions which deserve our attention every bit as much as patients with COPD.
Steroids, in my mind, are actually quite simple, and John laid it out very, very nicely. You can look at 2 things you need to consider when you whether to give someone a steroid or not. Number 1 is the risk of exacerbation, and risk of exacerbation in the main is predicted by previous history of exacerbation, whether it's moderate exacerbations or severe exacerbations, and so gold helps us with that. And then the other thing you need to consider is the blood eosinophil count, because again there's clear evidence both prospectively and retrospectively that as your eosinophil count increases, your risk of exacerbation goes up, but even better, the response to steroids goes up. I think that's really important to say. So basically, if you haven't had exacerbations, and that's what steroids do, is reduce exacerbations, you pretty much don't need an inhaled corticosteroids unless your eosinophil count is significantly elevated. We'll perhaps talk about that. If your eosinophil count is above 300 and you've had exacerbations, you definitely should be on inhaled corticosteroid. If you have an eosinophil count below 100, there is no benefit from the inhaled corticosteroid, as John has said, so you don't need to be on them. And then there was a bit in the middle where you have to consider the risk-benefit, as John laid out, with pneumonia versus exacerbation risk, of reduction risk of the inhaled steroids. And basically, if your eosinophil count is higher, you've got more risk. So actually, I would consider a high number of exacerbations plus an eosinophil count above 100. I would consider inhaled corticosteroids, but below 100, certainly not. So that's how I kind of see it. I think it's quite simple, and people get very, very hung up about it. But the beauty thing is, with the eosinophil counts and the exacerbation risk, is steroids, inhaled corticosteroids, reduce exacerbations. Eosinophils predict response to inhaled corticosteroids, and so it's very simple to give them to the right people.
Richard, before we leave that point, I think it's also important for you to comment on the dose of inhaled corticosteroids we use in COPD as opposed to in, well, mild asthma for a start. There's a big difference there as well.
So that's a really good point. Let's deal with the reduction or the taking them off steroids first of all, because again I think it's relatively simple. If and there's always a chicken and egg argument here, which we can have. But if you've not had exacerbations and your eosinophil count is below 100, you should not be on inhaled corticosteroid. And it's reasonable, and that's what the ERS recommendations are. You can probably stop the steroids abruptly. Sure. If you've not had exacerbations, your eosinophils above 300, you probably should stay on the inhaled corticosteroids because the steroids are probably working. I think that's really important to say. Sure. But if your levels are in between, you haven't had exacerbations, then withdrawing people from steroids is a reasonable thing to do. If you've had no exacerbations, the guidelines say, I'm actually consider 2 years as being a proper phenotype changer. Now, whether you take them off slowly or abruptly, I think there's very little evidence to help us, but in my practice, I do this in a stepwise way for people with severe airflow obstruction. Because for them, you get a small reduction in FEV1 when you reduce a steroid, which may be clinically significant. But for someone who's got good airways with reasonable FEV1s, I just stop it completely. And then John's point about the dose of steroids. Do you know what? This is also really difficult because all of the steroid trials were done with really high doses of steroids compared with what we use for asthma. However, and the benefits were there to be seen in the people with exacerbations in eosinophils. Not many studies were done with lower dose. Some were and were ineffective, but maybe they were looking at the wrong people, so it's hard to say. So we do need more studies on lower dose inhaled corticosteroids. But I have to say, John, you're right. The risk of pneumonia increases with dose of steroids, and we do have to use medium to high dose of inhaled steroids in COPD to be sure of the inhaled corticosteroid benefit with eosinophils. There's been a recent study with IDEAZZZZ, the IDEAZZZZ study, which has shown an effect in the people with high eosinophils of a lower dose of inhaled corticosteroids. So this is hinting that maybe we can use lower dose of inhaled corticosteroids, but not recommended at the moment.
So thank you all both so much. We have some questions before we end. The first question is from a doctor from Nepal.
I'm Dr. Pramod Bhatta, consultant general practice nurse working in the rural setting of Nepal under limited resources. I have a question for today's panelist. Actually, how to differentiate between asthma and COPD. Actually, in our day-to-day practice, there are a lot of overlap symptoms between COPD and asthma that makes it really difficult to differentiate between asthma and COPD. So if the panelists could differentiate between them and make it clear for us, it could be really helpful for a lot of general practitioners working in the rural setting with limited resources. Thank you.
John, you'd like to take that one?
So we've got to be a little bit careful not to presume that all people with asthma have got similar symptoms and all people with COPD have got similar symptoms. But in general, people with asthma have an intermittent symptom cluster. So they can be well for periods of time with episodes where they are less well. They often have symptoms that started in childhood. They're often atopic individuals. And so one of the features I see in primary care asthma, so let's leave aside the most severe asthma, is that for periods of time, people can be particularly and completely well. And this is a good diagnostic feature, but also quite a difficult feature in terms of managing the patients, because they wonder why we are treating them when they feel completely well.
Right.
On the other hand, you can't really have COPD until you're about 40, because you've got to have a 20-pack year history of smoking. So, you'll find a few people who started smoking very early who have developed COPD before that. But in general, people with COPD are less than 40. They'll always have a smoking history or an exposure history. They will have progressive symptoms, so that the features they have occur day after day. They'll have a reproducibility in terms of their breathlessness. If they can't walk to the shops, they can never walk to the shops. Somebody with asthma might have episodes where they can't walk to the shops, but other days they can walk to the shops. So that can't be COPD. But the point I would really like to make is this idea about COPD doesn't trouble you at night, but asthma does, is a bit of a fallacy. I know lots of patients with COPD who've got symptoms at night. Patients who have symptoms mostly in the morning tend to have asthma. I don't think that's true either. Patients with COPD are particularly bad in the morning. It's difficult to get patients with COPD to come to early morning clinic appointments because they just literally can't get up quickly enough. COPD patients and teenagers, they can't get up in the morning. So there's a cluster of clinical symptoms that will guide the clinician, and then there's a whole lot of supporting features such as blood eosinophil counts, phenos, and of course measurements of obstructive airways disease.
I think you
You
summarized.
can't rely on a trial of treatment to help you with the diagnosis because a short-acting beta agonist should make both lots of patients, both asthma and COPD patients, better. So don't rely on a trial of treatment to differentiate.
Sure.
To make a diagnosis supported by other features is okay. So there's symptom clusters, there's objective evidence, and then two different treatment pathways, Suji.
And would you also add a family history of atopy as favoring asthma?
Indeed. So there's not one feature. That doesn't, because you've got a family history, it doesn't mean you must have asthma and you can't have COPD, but these are little extra pieces in the jigsaw, you know, or weights on the balance, which make it possible to make a confident diagnosis one over the other, confirmed by spirometry, reversibility, pheno levels, eosinophil counts, sputum eosinophils if you work in Richard's department, and so on.
Super. And the next question, and Richard, I'll pass this to you. I will have to get you to come from a COPD specialist to absolute primary care, stranded on an island.
Hi, I'm Dr. Mahesh from Sri Lanka. My question is, I don't have access to spirometer. How can I diagnose COPD?
Talk to the patient properly. Talk to them well. Ask the right questions. I don't think it you know, to ask you and use your hands. I mean, I'm actually, you know, I'm actually almost absolutely serious about this.
Sure.
You know, and use your face. So basically, it's talking, asking the right questions, talking about the impact. What is actually the problem?
Right.
What are the symptoms the patient's having? How have they developed? And actually, what has been the impact of those symptoms? That also really helps you with treatment.
Sure.
And then actually looking at the way they breathe. You haven't got a spirometry, but you can still ask someone to take a big breath in and big breath out, hard and fast, like a spirometry, and you can see the pattern of their breathing, which will give you a really good understanding of diagnosis. And then obviously, from an examination point of view, looking for the signs of remembering.
Sure.
COPD is a multi-system disease in a way, or has multiple effects anyway, of looking at the cardiovascular system, the respiratory system, with hyperinflation particularly, and also then the musculoskeletal system, looking for the impact of a disease on someone's muscles to find out again what the benefit is.
Sure.
Because, Suji, I would love there to be a world where actually we are using those skills with the appropriate tests, without necessarily labeling for a diagnosis, and having treatments which are individual for a patient, that are following the results for that individual patient, whether it's the blood eosinophil count, whether it's a spirometry trace, or whether it's a particular symptom score. It would be wonderful. So absolutely. So you can use those things, ask the right questions, and examine the patient properly.
Sure. And maybe add in a chest X-ray, especially in a country like India, where I work, you know, to rule out tuberculosis and probably any other cause.
And also, tuberculosis has significant long-term morbidity in the lung, and is a significant cause not only of bronchiectasis but also related to chronic airways obstruction and a type of COPD.
Sure. And the third question is from Myanmar, and I put this across to John.
Hello, I'm Dr. Sai from Myanmar, and I would like to ask, in the era of COVID-19, how to manage our COPD patients?
I think in general, the management of COPD and the management of COVID haven't caused us particular problems in terms of the interaction. Now, there's a few specifics we need to be aware of. For instance, in many parts of the world, spirometry hasn't been conducted for more than a year because of the concerns around transmitting infection by conducting spirometry. So we've been somewhat hampered. But in terms of the pure management of COPD in the time of COVID, acknowledging that it might be done more remotely and less intensively and so on, nothing's really changed. And in terms of managing COVID in people with COPD, the experience from my hospital is that although outcomes can be different and people have speculated on the roles of different therapies, and we can presume that people who have a underlying pulmonary comorbidity are going to do less well, the role of managing people with COVID in the presence of COPD is no different to managing COVID in somebody who doesn't have COPD. So there's no particular issues, although the finer points of management are obviously influenced by the fact that the whole healthcare system has changed in terms of person-to-person contact.
Thank you very much, both of you all again, and I really appreciate your time today. So I would again like to thank you for tuning in, and also thank our collaborators, very importantly, which are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPATH from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. And I look forward to meeting you all again in this Season 2, Episode 9 in the near future. Thank you.